Hello and welcome to our very first Medicine for Members talk. My name is Nikki Barnard and I'm the Membership Manager here at Addenbrooke's. And tonight we are really excited to be hosting our first virtual Medicine for Members with Mike Moore as our chair and our host this evening. So Mike, thank you so much for joining us.
Thank you. So thank you very much and good evening everybody on a slightly wet but also sunny evening here in Cambridge. So it's great to have you all join us. So thank you very much indeed for that. It's a great pleasure to and also a great responsibility to chair an institution that is important to so many hundreds of thousands of people. I think I can say hundreds of thousands of people over the years. It's a huge institution and we all take our responsibility for healthcare of everyone who we serve very, very seriously. So tonight we normally hold these sessions as regular every so often. We normally, of course, use them to share the work that we do in the hospital in Addenbrooke's and the Rosie with you. And as you all know, we usually do these face to face, but we've all got used to a very changed world over the last few months. And all become, I hope you'll judge that all of us on the panel have become expert in videoing and talking in front of camera. I'm confident our colleagues will demonstrate their expertise in that way. But we would appreciate your feedback actually on whether this works, because I think, as we all know, we could be in for this kind of style of communication for a while to come. And it's important as a hospital that we keep our communication channels going. If you're watching, but you're not a member of the Foundation Trust, and our membership is very important to us, then please do visit our website, www.cuh.nhs.uk, because you can find out information there as to how you become a member. So please do let us know if it's of interest to you. So this session, I'm joined by some 4 fabulous colleagues who've been really important in the last few months, and I'll introduce each of them in a second. But it's focusing on how we have responded to COVID-19 at Cambridge University hospitals. Colleagues on the panel have all been absolutely central in leading our response, either as a hospital or connecting into primary care and supporting each other, primary care and the hospital, in how we have responded to what is an unprecedented in our lifetimes position. And there'll be an opportunity after they've each spoken to ask questions via Facebook Live. Just add your comments or questions to the comments section, and hopefully we'll be able between us to capture those and then raise them in the discussion after my colleagues have spoken. And hopefully not to worry my panel colleagues too much, a recording of the lecture will be made available on the CUH website. So this will be, I don't know whether it's in perpetuity or at least for a finite period of time. So I hope my colleagues aren't overly upset about that prospect. So, I'm going to, without further ado, I'm going to introduce our speakers. And if I introduce them in total, and then I'll introduce one by one as we go. So we have Dr. James Morrow, who's a GP and Managing Director of the Granta Medical Practice in the south of the county. And James is someone with whom I and other colleagues in the hospital have worked very well over the last few years, and the relationship between primary care and the hospital is an increasingly important one, and one in which we hopefully recognise the mutuality of having a good acute hospital and a good primary care system working side by side, because you as patients need that. So I'll be handing over to James in a second. Then after that, I'll be handing over to Charlotte Summers, Dr. Summers, who is a part of the clinical school, part of the research, the University of Cambridge consultancy base that we have within the hospital, but Charlotte's been doing absolutely amazing work, both in the research and in intensive care, which I think anybody who's been watching the television over the last few months will fully recognise the challenges that have existed in intensive care through this period. So we're delighted to have Charlotte with us. Then I'll pass on to Dr. Ben Warren, who's Specialty Registrar in Infectious Diseases and General Medicine. And again, Ben and his colleagues have been absolutely instrumental in the way we've tackled what is a pernicious and really wicked infectious disease, and really challenging in all kinds of ways. So Ben's input to that has been, again, huge, and I'm hugely grateful to him and his team for that. And then finally, I'll hand over to Nicola Ayton, who is our Chief Operating Officer. And some of you will know what a Chief Operating Officer does. Nicola, I'm sure, will tell me one day what she does. But seriously, she's a huge. Her responsibility is really to make sure that the hospital as a whole works. So it's managing the patient flows in and out and through the hospital, and working with the clinical leaders and nursing staff, etc., to make that work, which is a hugely challenging challenge at the best of times, and has been particularly difficult over the last few months. So without further ado, if my colleagues are okay, I'll hand over to James, Dr. James Morrow, GP Managing Director of Granta Medical Practice. James.
Mike, thank you very much indeed, and thank you everyone for tuning in, listening to this evening's talks. I'm going to share my screen now, which I hope will work as anticipated. So as Mike has said, I'm the managing partner, I'm a GP here at Granta Medical Practices, and it's a quite a large general practice that we have 5 sites across South Cambridgeshire, from Shelford through Sawston to Linton, Barley and Royston. And we have about 165 staff, 32 GPs, working incredibly closely, as Mike has alluded to, with our colleagues in the acute sector, as well as those from the voluntary, charitable and social care elements. And with Nicola Ayton, I co-chair the South Provider Alliance, which tries to bring all of these agencies together to better coordinate care across the entire sector. Charles Dickens, the starter of A Tale of Two Cities, is probably well known, that it was the best of times, it was the worst of times. I think what's less well known is, as he moves through that opening paragraph, he talks about it being the age of wisdom. It was the age of foolishness. It was the spring of hope and the winter of despair. And as Mike has said, we've been through a very dramatic period, social, economic, healthcare upheaval. And I think in this context, it's very important that we just remember that this isn't an abstract illness or disease, that nearly 500 of our fellow citizens across Cambridgeshire and Peterborough very sadly died from or with this condition. And clearly our thoughts are with them, their families, their loved ones, for whom this pandemic has been not an abstract concept, but brought great personal tragedy and real grief. To set some context about primary care, you might wonder why a GP is part of a Cambridge University Hospital's talk. And the answer, as Mike has alluded to, is that we are part of the same system. This chart shows the number of contacts in 2018-2019 across Cambridge and Peterborough. Running down the left-hand side are the various providers delivering healthcare activity. And for example, you can see that NHS 111 does about a 250,000 contacts a year. But what dwarfs all of this is the contribution that primary care makes to the contact numbers. So about 5.18 million contacts a year are delivered in primary care across Cambridgeshire and Peterborough, vastly dwarfing every other part of the system. And because of that, it's very important that primary care and the rest of the system work together, as a small change in primary care could potentially have major impacts elsewhere within our health and care system. We need to maintain stability, really, for everyone's benefit. And when we think about urgent care, which means care delivered within 24 hours through to seven days, some 85% of that occurs in primary care. So primary care picks up the bulk of urgent and emergency care. It delivers the bulk of patient contacts during the course of the year. And a little bit more data in our practice alone, these are the phone calls on one day in March of this year. So nearly 3,500 phone calls, about 4% of our population, 1 in 25, ringing in for a telephone consultation on one day alone. So primary care knows its population well, is fully engaged with it, and has regular contact. But then we come to coronavirus, and everything has changed. Where we used to see people face to face all the time as the default way of dealing with things, we've had to completely alter that pattern of behavior. And the reason for doing that was that all of us saw those memorable images coming out of northern Italy at the start of the coronavirus pandemic of army lorries carrying coffins out of the city because they were overwhelmed. And action was clearly needed here to protect ourselves, our staff, our population, our patients, and to protect the system. So as hospitals geared up with clearing beds, cutting down on routine elective activity, on expanding the number of intensive care beds, as Charlotte will allude to, so we in primary care had to change and transform what we were doing as well. And our objectives were clear, that it was to do the most for the most. We had extreme uncertainty about what we were facing. We knew there would be resource constraints, but nonetheless, it was clear that we had an obligation to do the best that we could and to prepare for what we thought might be coming. So one of the first things we did was we moved to remote by design, remote by default. Waiting rooms emptied as we dealt with all patients for the first point of contact on the phone. We aim to deal with 90% of patients remotely, whether that's by phone, by email, by text messaging, or by video consultation, a completely new technique that was switched on in our practice, like most practices across the country, more or less overnight at the start of the pandemic, thanks to support from our clinical commissioning group colleagues and a fantastic bit of software which was provided freely across the entire NHS by a startup company which trumped anything that had been available beforehand and was adopted overnight and universally and is still absolutely embedded in what we do and how we do it. But it hasn't just been the response of the health service, it's been our community as well. Volunteers who have looked after each other, our patients, helped with drug deliveries. It's been the volunteers who have made scrubs for us in the early days when there was a shortage and helped manufacture through schools and 3D printers, face visors, again in the early days when there were PPE shortages. Food deliveries from local businesses and clapping for carers made an enormous difference to so many of our staff to know that the efforts that they, along with all our colleagues across the health and care sector, were making were appreciated. It's something that was actually very, very powerful, and it all made a difference. One of the questions that's being thrown back at general practice is, well, the front doors are shut, you must be doing nothing. This is a run chart from one of my colleagues, Neil Moder, who is a GP in Peterborough and Thistlemore. And this goes back to September 2018 and effectively shows that apart from a minor dip at the time of lockdown, general practice activity has continued unabated throughout this pandemic. We've changed how we've delivered care, but actually the numbers and the contacts have remained pretty constant. About 1 in 10 of our contacts are now face-to-face. We've resumed things like essential services such as childhood immunisations, phlebotomy, depot injections, but we're still trying to maintain safety of our patients, our staff and the broader population by minimising contact unless there's a clear benefit. Before COVID, our local system was already stretched, as many of you will know and understand. And we have to face the future that actually COVID will require us to adopt new, safe ways of working until we have an effective vaccine for this condition. So given social distancing, PPE requirements and enhanced hygiene, cleansing regimes, we know that in this practice alone, that if we were to try and deliver the same face-to-face activity that we did pre-COVID, we would need to increase our staff numbers by 53%. And that staff pool simply doesn't exist. So going back to the way we were doing things is not a realistic prospect. We will have an altered way of working for the foreseeable future. And I think similar challenges face our colleagues in CUH. And that really underlines that this is a system-wide issue. And it's only by working as one team around our shared population that primary and secondary care, Cambridge University hospitals, will continue to deliver the best possible care for the population of this region. Going back to Charles Dickens, the worst of times, the winter of despair. We have seen families devastated by the impact of this novel disease, and we all also know of colleagues who have been struggling with the impact of the illness and disease either on them, their families, or in those that they've cared for. And we're all still enduring constraints on our freedom that were unimaginable only 6 months ago. And the mental health consequences of lockdown and the dawning reality of economic downturn are increasing issues for many of our patients and increasing reason for contact across primary care. But it's also, as Dickens alluded to, the best of times and the spring of hope, that we have experienced in the health and care sector a cohesiveness of spirit, of mutual effort and community pride that has helped reaffirm our collective belief in the NHS. And I know, speaking as a resident of Cambridgeshire and as a GP of Cambridgeshire, that we are intensely and immensely grateful for the world-leading expertise, technology, research, all underpinned by human kindness that is Cambridge University Hospitals. We are indeed fortunate to have such a great hospital on our doorstep and to benefit from its care through this crisis. I'll stop there, Mike. I'm very happy to take questions, which I gather are going to come at the end of all our presentations, but thank you very much, everyone.
Thank you very much, James. That was enormously helpful, and thank you, and gave a very clear picture. And aside from that, there is always the benefit of listening to James, because my knowledge of literature always improves whenever I hear James. So can I pass over with, and we'll take, please do ask questions on Facebook Live, and we'll pick those up at the end and connect them up as a conversation. So shall I hand over to you, Charlotte, and the perspective in intensive care? So over to Charlotte. Thank you.
Thank you. I'm going to try and share my screen as well, so just bear with me for a moment. So I'm hoping that you can all see a picture of the rainbow on. So I'm Charlotte Summers. I'm one of the intensive care consultants at Addenbrooke's, but also the university lecturer for intensive care medicine, which means that when we're not in times of COVID search, actually I run a research laboratory alongside my clinical practice. And the journey for COVID for the intensive care started a little bit before this, really, when we were reading over Christmas the comments, particularly on social media, from our colleagues in Wuhan, who had initially noticed that they had a strange selection of patients admitted to their intensive care units that were different to they normally saw, with a particular type of pneumonia for which they didn't initially find a diagnosis. And it looked more and more concerning, and more news was coming out about it. And so we decided that we would have an MDT, so a multidisciplinary meeting between us, our virology colleagues, our infection control colleagues, and a variety of other people across the hospital at the beginning of February. And here you can see us learning about the timeline, courtesy of one of our registrars, about the events that had happened in Wuhan, so that we could start thinking really early about what we might need to do, and if things didn't develop in a way that we all hoped that they would, and we ended up with a pandemic, that we were prepared as well as possible. And then shortly after that, the paper with the actual data appeared from Wuhan, and we all got even more concerned because it looked like there was probably asymptomatic transmission of the virus, which meant that people who were infected didn't know they were infected when they were still passing it on to people, which meant that the chances of it causing us a problem in the UK were greater than it would have been if that hadn't been the case. So we started our planning in earnest. Then everybody else started to get a little bit nervous too, and the Health Secretary on the 1st of March announced that we probably needed a few more intensive care beds, by which point we had a firm plan for how we were going to expand intensive care beds and how we were going to manage clinically to deliver intensive care services in the setting of coronavirus. And then a lockdown was announced on the 18th of March, by which point we were really well established, despite the fact that actually weren't very many cases locally to us at this point. And what do I mean by established? Well, we had already opened, and this is a photograph I took on the 25th of March, we had already converted beds that we would normally use as ICU step-down beds to beds where we were able to do mechanical ventilation, so that we had trained nursing staff undergoing refreshers and staff from elsewhere in the hospital being trained, all of us practicing putting on our PPE, which you've all heard about, and taking it all off again, and doing all of the kind of procedures that are needed to deliver intensive care whilst wearing full PPE, which is not a small undertaking. So we were doing simulation drills, we were doing everything we could think of to prepare and opening up extra beds. Then on the 4th of April, it was all over the news, so I'm sure all of you will have heard, our colleagues in Watford needed a little bit of urgent support for their intensive care unit. And this is a photograph of the team that we sent in a couple of ambulances to Watford to help decant their intensive care unit when they had trouble with their oxygen supply whilst having a very full, in fact, an overflowing intensive care unit. And the reason I'm showing this is that it took a network to respond to coronavirus. And yes, I'm talking about the Cambridge University Hospital's response, but actually it was a response from the whole critical care network across the east of England and beyond, because none of us practices in isolation. And then by the 8th of April, we opened up even more intensive care beds because we thought we might need them and we'd filled the other ones. And so we opened another 23 beds on a ward called J3 in the hospital that 9 days before had been a hospital ward used for something else entirely. So we'd had a tremendous support from various different services across the hospital, including the decorators, the engineers, you name it. They came and helped us to convert something that was a hospital ward into an intensive care unit that we could admit patients into. And these three lovely ladies I felt I needed to highlight because they're the people that essentially did most of that work. So one of them is Sandra Rees-Pedler, who used to be one of our critical care matrons, who came out of retirement to come and help us. And the other two are some of our healthcare support workers who just were amazing throughout this, and we could not have got through without them. And I think it takes a team is the one message that I would want to emphasise the most. It took consultants from critical care and anaesthesia and across the hospital to deliver what we have been able to deliver to get through. Junior doctors from our institution and from elsewhere came to join the ICU to make sure we had enough staff. We needed nurses from across the hospital, operation department practitioners, healthcare support workers, pharmacists, physios, admin staff. The additional ICU we opened, the ward clerk for that was actually the ward clerk from Ely Day Surgery who came to work and be the ICU ward clerk in an environment that she'd never experienced before. We needed speech and language therapists, procurement, engineering, chaplaincy, everybody you could possibly imagine. And they're rarely thanked, but I would like to recognise them, and it's the hospital management team. Everybody from the chief executive down to our divisional managers to our operations managers, and Nicola and her colleagues will know only too well they had to suffer me on the bridge on a daily basis to help us get through this intensive care pressure that we don't normally have. And they were phenomenal, and without all of us working as a team in a coordinated fashion, we wouldn't have managed to deliver what we did in such a short space of time. And I think the other lessons that we've probably learned that I wanted to share were about preparedness being everything. I think we got through in relatively good shape so far because we started early and we had a clear plan, and we had an idea that it probably was a marathon, not a sprint. And although we are all pretty tired, actually it could be worse if we hadn't made the plans that we did. Communication has been critical on every front. I think from James talking about communication in primary care to even people like me actually have been joining the STP calls so that we can have joined up between primary and ICU, which I don't think has ever happened in anybody's careers previously, to us communicating with our families, and I'll talk a bit more about that in a minute, communicating to the rest of the hospital and the public that it's okay, we've got a plan, it's safe, please come to the hospital if you're sick. And the importance of research, and again, more of that in a second. So communication, as was well publicised, we didn't have any visitors in the intensive care unit, and that was a national policy, which made it incredibly challenging for the patients and their families, and for the staff because intensive care is the time when you most want to be with your relative and your loved ones. It's the one where actually you most want to sit with the doctors and find out what on earth is going on. Is everything going to be okay? And not being able to do that, and not being able to necessarily be with your family members when they're dying, was an extraordinarily tough thing for any of us to ask of families. And I think that that should be recognised. But many of our colleagues, and particularly Rowan Bernstein, did amazing work to try and mitigate the stress of that as much as possible by setting up communication routes and by using technology as best we could to try and minimise the impact. And in fact, the response and the work on that was so good, we featured as the leading article on Sky News about it on one day. And this is just a clip from Rowan on Sky News. Research has been central to our response to coronavirus in the ICU. As you might imagine, dealing with coronavirus in ICU is tough enough, but actually we made an early commitment. We were going to try and enrol as many of our patients as we could into the national research studies. And I am delighted to say that instead of our usual 10 to 20% enrolment in research studies in the ICU, which is nationally leading, we're well above 50%. So 59% of our, or 59 of in total of our coronavirus patients went into a thing called Genomics, which looks about if there's any genetic predispositions to why people might have got sick with their coronavirus compared with people who didn't. And so far, we've got 4 people in one of the national intensive care platform trials called REMAP-CAP that looks at novel interventions. And one of them is actually one of the UK's first patients in ICU to get convalescent plasma, which was an idea that was generated between David Menon, the Professor of Anaesthesia here, and the National Blood Transfusion Service. So it's Cambridge research that we are delivering alongside everything else. And I think we should be really proud of that. Delivering any research in the setting of an ICU surge is a big ask, but to have done more than we would do any other day of the week shows what can be done when you really try. And I was going to stop there and listen to Ben.
Thanks very much, Charlotte. That was terrific. And I think there's lots of points in there, but the point about it takes a team, you were very strong on that, and that's really important. The other point is a bit of a personal observation by me, which is that I'm always struck that intensive care at one level is the highest tech bit of the whole of healthcare provision. It's got that very intensive technical aspect to it, but it's also treating patients, and in this case, their families remotely at their most vulnerable in their entire lives. And that sense of vulnerability and that sense of treating a patient as a person, despite all the technology, I'm always astonished by how our colleagues in intensive care pull that off, and it is really, to use a word my son uses, awesome. So it's great. So I'll now hand over to Ben, who, because understanding what the nature of this disease was and the ability to model it, because we didn't really, I mean, this was new. So Ben, over to you.
Thank you very much. So what I'm going to do is talk you through our last 6 months of our experience of COVID-19 here at CUH, what that experience has been in terms of numbers and data, and how we are learning from that in collaboration with other groups across the biomedical campus, and how we can apply that information to help us to continue to provide services in the future. So, like many infectious diseases doctors, I first heard about COVID-19 6 months ago, so New Year's Eve last year, when this message got circulated on our email distribution lists, that there was an unknown pneumonia in Wuhan in China that had been isolated from multiple hospitals, but we didn't know what it was. And here we are 6 months later, where this has been confirmed as a coronavirus, and the number of COVID-19 infections has topped 10 million people worldwide. So what I want to do is talk to you about how that's affected us locally and what our numbers have been like. So we had our first confirmed case here at CUH on the 10th of March. And this graph shows how the epidemic has progressed over the last 3.5 months. So if I superimpose here our UK lockdown, which started on the 23rd of March, like many other centres around the world, North Italy, Wuhan, the rate of increase peaked within the 2 to 3 weeks post-lockdown and has gradually reduced. And over the last few weeks, we've had a dramatic reduction in cases, and actually more often than not now we're having no cases being diagnosed, nor any cases. If we look at this in a bit more detail, in total we've had 525 patients diagnosed here at CUH, of whom 489 have been admitted as inpatients. We've had 96 admissions to intensive care, as Charlotte's just discussed. But the key thing is that 312 of these patients have been discharged well. We have had over 100 deaths in our patients who are diagnosed here at CUH. If we break those numbers down a little bit further and look at the age distribution of these patients, so here the red bars are female patients, the blue bars are male, broken down by age. We see quite a familiar story that's been told time and time again on the news, which this is predominantly a disease of older people, especially men. And that's reflected both in the total numbers and in the number of deaths we've had represented by these darker bars. Another common question we asked about is ethnicity. And if we look at our COVID-19 patients diagnosed here, the vast majority of those have been white, with the ethnic minorities represented here in orange. And that 8% figure is roughly the background mix of our population in our local population. And although we have had a higher proportion of ethnic minorities admitted to intensive care, the overall fatalities has been at a slightly lower figure. Now, these numbers actually get quite small when you boil down to them, but it is something we need to sort of bear in mind as we look at the picture nationally, as more and more information becomes available on ethnic minorities and how this disease is affecting them. If I now return to that curve, the epidemic curve of the number of cases that we've had in CUH, and again, look at that UK lockdown. What we've been doing is trying to let's break this down, this curve a little bit further, to see if we can try and ascertain where these types of infections have come from. So the green bars here represent the cases that we think were required in the community. So these are cases that haven't had any relationship with hospital or haven't been with us recently or haven't been in hospital at all in CUH. We can break that down again further to explore an issue again, which has been well publicised in the news, about care homes and institutions. So here the yellow bars reflect the number of patients that were admitted to CUH from a care home. And bear in mind that if we had lockdown here, the total number of patients from care homes actually continued to increase for a period of time after lockdown had stopped. Like most of these cases, we've now got that under control, and the number of patients being admitted from care homes is dramatically reduced in the last couple of months. What we're particularly interested in from an infection control perspective is the number of people that may have acquired their infection in hospital. So we didn't know anything about this disease 6 months ago, but it has become apparent that hospital transmission of COVID is a really important mechanism by which you can have ongoing transmission of the virus. And here in this, the pink colours here represent patients who may have acquired their infection in hospital. The difficulty with this virus, it has quite a long incubation period. So the time from which you have contact with the virus to the time that you're actually symptomatic with it can be anything up to 2 weeks. So for any patient that develops symptoms of COVID, even up to 2 weeks into their admission, that would present at hospital with something else, may reflect an infection that either came from the community or came from the hospital. We've done a lot of work trying to ascertain why that is. You'll notice again that our number of hospital-associated infections has dramatically reduced. And that's because we've, like many hospitals across the country, across the world, have introduced a really wide-ranging array of interventions in terms of infection control and PPE, so personal protective equipment, both for staff and for patients' benefit, which again has reduced the number of cases that we've had quite dramatically. In addition to that, if I then superimpose these blue bars, these are the number of healthcare workers and household contacts of healthcare workers that have been diagnosed with COVID in CUH, the vast majority of which had very, very mild illnesses that didn't cause them to be admitted to hospital. I think we should be quite proud of the collaboration we've had here at the University of Cambridge, setting up what was one of the first healthcare worker screening programmes anywhere in the country, which kicked in on the 6th of April and rapidly expanded so that we're now able to perform several hundred tests per day, and I think now over 10,000 tests we performed in total. And you can see that in the first couple of weeks after the screening programme was introduced, we put a relatively large number of healthcare workers, the majority of whom were asymptomatic, really, really important, as Charlotte mentioned. But again, we've managed to, well, we've reduced the number of healthcare workers who've had an infection, partly due to the PPE, partly because of community rates going down. But we're able to keep a very close eye on our healthcare workers. And as soon as we have identify any infections there, our infection control team and occupational health and others can focus in very closely on any potential clusters or outbreaks that have been very, very thoroughly investigated immediately. One of the key collaborations we've had with the university is to try and study where these healthcare workers, where these potential hospital-associated infections have come from. And one of the ways that we've been doing that is looking at the genetics of the virus. So this is a tree of the virus, looking at the genome of the virus, so the genetic code that makes up that virus. And this is like a family tree turned over 90 degrees onto its side, where at the top here, we have the great-grandfather of all of these, which is a strain of the virus from Wuhan. And also we have 299 viruses that were diagnosed here in CUH. Now, the further apart you are on this tree, the more distantly related those viruses are. And two very closely related viruses come sit very closely on this tree. And what we can do is use this kind of information to look at strains that are very, very closely related together, suggesting that they have recently been transmitted from person to person. And here I've given you three examples in green, orange, and yellow, which represent identical viruses in groups of patients who were on the same clinical unit at the same time. So two of our wards and our dialysis unit, which had outbreaks very, very early on during the course of the COVID-19 experience here at Untitled. What's really important to note is we can use the same kind of technology to look at outbreaks in the community. And these pink bars represent an outbreak in a local care home, which involved care home residents and carers. But also in parallel, what appears to be a cluster of cases in paramedics and CUH staff, where actually they acquired the virus out in the community rather than the hospital. And using that kind of information, we can pick apart the transmission that we're seeing, particularly after lockdown, where we're having fewer and fewer community cases, so that we can act very, very promptly to try and control these. And this is a story that we're hearing time and time again from around the country, around the world. We're really leading on how we can understand and control these outbreaks here in Cambridge. So in total identified outbreaks across 12 wards, pretty much all of those were in the early days of the epidemic, and we've really, really managed to get on top of those now. So finally then, what is the future of COVID here at CUH? There is an enormous amount of uncertainty about what's going to happen in the next months and realistically to years. What we do know is we have a wealth of data that we can draw upon to help us to prepare for whatever comes next. And we can use this to try and reduce the risk and to try and keep our patients and our staff as safe as we possibly can. Part of this is balancing the risk, as James mentioned, where we know that we are dealing with a disease which is out in the community, but actually at the same time, we still have to maintain the level of care we provide to all of our patients for all of the other conditions that we haven't been able to manage as effectively in the recent past. We're also using this data to predict our future needs. So as the cases go up and down in the community, how we're able to balance the number of intensive care beds, general medical beds, oxygen supplies, and so on, that are really key in determining the kind of impact it will have on CUH in the near future. And as the evidence base expands and more treatments and technologies come online, we're well prepared to incorporate those into our clinical practice. And one thing I want to finally leave you with is a local project here about rapid diagnostics. So this is using a technology called SAMBA, which was developed here at the University of Cambridge and was piloted here, led by Professor Ravi Gupta's team, where we were introducing a point of care test. So this is a test by the very, very close to the patient's bedside, where we can reduce the amount of time to get a COVID diagnosis by nearly 24 hours, to reduce the length of stay on these wards where we're not sure the patient's got COVID or not by 18 hours, and to avoid unnecessary bed closures. That's having a big impact on our infection control policies and procedures. And this is one example of a great collaboration between us here at the Trust and our local university partners. So in summary, we've had an enormous amount of impact on COVID on CUH to date. We're really working hard to understand how our patients have been affected by this and how we can best manage them, which has involved many, many collaborations across the biomedical campus. And while the future is uncertain, we are increasingly well prepared. Many thanks to all the COVID-19 patients and the staff caring for them. And this is just a tiny fraction of the people in the trust and across the campus who've been assisting us in our efforts to try and better understand this disease. I'll stop there. Thank you.
Thank you very much, Ben. That was really, really helpful and powerful, and brought out again, you know, we're a teaching hospital and a research hospital. So the research aspects that Ben was talking about there in terms of understanding the disease, diagnosis, testing, and linking also to the points that Charlotte was making about the research interventions. We have a heavy responsibility to help the global fight against COVID, and that's part of our role. But also, I think, and Ben kind of really understated the contribution he and his team made to the whole way in which the hospital understood what was going on in order for us to be able to care for patients. I think, you know, Ben has understated the value he has had to the whole of the hospital in understanding the disease and the impact of the modelling. And, you know, not every hospital was able or had the capacity to do that. Sometimes some healthcare providers, because of the nature of their institution, we're getting their kind of information in a sense from the national picture, whereas we were actually using the depth of experience and know-how in the hospital to help inform the clinical leadership that has been so important and so valuable to us as a hospital. So thank you, Ben. I'll hand over Nicola then. So the operational task, and this is huge. So Nicola, over to you.
Thanks, Mike. Yeah, that's right. So I don't have any slides. I'm just going to talk to you about how we're really approaching this next phase as we continue to provide services, treat patients, and run a hospital during the COVID outbreak period. So I think you've heard from Charlotte, Ben, and James that really that first phase was very much about how we really scaled and reorganized our services, the way we work together and the way we care for patients in order to respond to that first surge in COVID patients. And you've heard about how that was a multi-professional effort, a whole team effort across the whole system, across the regional critical care network, and across both clinical service provision and academia and research. And you've heard about how we were very much driven by the data and what that was telling us about likely scenarios that we needed to plan, prepare, and scale for. You've heard about how we used the real communication and real data we're getting day to day to keep adjusting our approach and to plan for the next week and the week after that. And you've talked about the emphasis on we've talked about the emphasis on communication across organizations, across existing professional groups, and crucially with patients and with their families. And all of those things need to continue to be features of the way we continue to respond to and run services during the COVID outbreak period. So we're now in this next phase, and Ben has talked about the very high levels of uncertainty that we are now grappling with and seeking to respond to, and again, plan and prepare for. But that's challenging, as you can imagine, and it's very complex because in that initial phase, we were talking about how we scaled to meet the needs of our patients with COVID-19. And in order to do that, we did have to stop doing some of the things within the NHS. And that's what happened in hospitals across the country. Now, James has talked about how primary care really managed to keep up its levels of service provision, primarily by moving to less face-to-face interactions and managing to do things remotely. And I think the levels of innovation and change that we were able to embrace and embed so quickly are to be applauded. There are other things that hospitals do that you cannot do remotely, and we had to stop doing those. So we're now faced with how we continue to meet the needs of our patients across the whole range of services we provide, both within the hospital, within primary and community care and social care, whilst also recognising that the global pandemic, COVID-19, has not gone away. And so we're very much focusing on how we now live with and respond to and understand the features of COVID, what that means for running a hospital during COVID, how we work across the whole system, and how we care for our patients. And our strategy over this phase continues to be to save lives and improve outcomes, to keep our staff safe and our patients safe, whilst also building for the future. And when we think about what that really means, as Ben has alluded to in some of the data he's shown us, that means when we think about how we continue to provide services to all of our patients and how we restart and reset those services, we need to be very careful about how we continue to embed really good infection prevention control measures. We continue to abide by very strongly with public health measures in order to keep levels of hospital-acquired COVID-19 as low as possible and continue to protect our staff and our patients. However, Ben has also talked about the need to balance those risks against the risks of not treating patients. And we are a hospital. And the thing that is now making us, is keeping us up at night and that we're all working together on and that we feel very strongly is that this is a place where we should be treating patients. And we are working every day to try to re-establish the levels of service provision that we had before the COVID outbreak. And when there aren't patients coming to the hospital, either because they're too anxious to come and then they're not seeking help in the way that they would normally, or they're not seeking help in the way that they would normally from primary care, we are worried about that. And we're trying to work out how we can address that in a way that's truly patient-centered while keeps our staff and patients and families safe. But we're also worried about the people who we know are on waiting lists, whose peak treatment was paused or cancelled during the COVID outbreak period. So we have people who are waiting for treatment who really need our input and need to come to the hospital for a clinical interaction or an operation. And then we have people who at the moment aren't able to access the right diagnostics. So they're not yet, they haven't yet been identified, their diagnosis hasn't yet been identified, and they're not on the right waiting list yet. And so these are the things that we are very much collaboratively across the hospital and with primary and community care colleagues focusing on at the moment. So I suppose I don't have all of the answers. What I would say is that across every domain of the hospital, and that's urgent and emergency care, diagnostics and outpatients, critical care and elective surgery, as well as how we interact with primary care. So that's specialist and secondary care input into primary care. Across all of those areas, we are now making significant progress to recover to our pre-COVID levels of service provision. And for instance, on outpatients, we are back up to levels of 70 to 80% in terms of the ability of our patients to access those outpatient services. However, in other areas, for instance, elective surgery, we're still running at very reduced capacity, which means there are patients who are not able to receive timely treatment in the way that they would have been before the COVID outbreak period. So there is a gap between supply and demand, between our ability to meet the needs of our patients and the extent to which those needs continue to exist. And that's something that we're working on all the time. And the things we're very focused on at the moment in this phase are, first of all, building back that capacity, because we need to treat patients and we need to treat as many patients as possible over this period, which, as Ben has said, could last for 18 months, 2 years. We need to sustain that capacity wherever possible over future surges, which means if we can build up some resilience and build up our ability to meet the needs of those patients if and when COVID levels increase again, without turning off other services, that's the right thing to be aiming for. And so how we sustain capacity and service provision is really key, and it's something we're all very, very focused on. Then how we use the capacity we've got in line with clinical need. So we are applying robust methods for really prioritizing our ability and our services that we've got, that we've managed to restore and recover in line with the needs of our patients, and always trying to treat those with the most urgent needs first. Having said that, we must always use all of our capacity. So what I mean by that is, if there is a gap currently between our ability to provide services and the needs of our patients to access them, if there is any ability to do that, we must meet the needs of our patients. So that might mean that where some patients are not able to be treated for something more complex here at the CUH site, but they might be able to be they might be able to access routine diagnostics or another type of treatment somewhere else in the community, and we're thinking all the time about how we can look at those options as well, then it may be that some people wait longer with more complex needs, but others are able to access other care in a different way. And so that's the thing we're trying to balance all the time, the way we allocate resource and capacity over this period whilst always maximising what we've got. And then finally, just to reiterate, we've got to keep our patients and staff safe over this period by minimising hospital-acquired COVID-19, but balancing that risk with the risk of not treating patients. So that's the kind of set of exam questions that we've set ourselves. And as I said, we've been planning for and delivering against those objectives really since the outbreak began. So as Charlotte said, you know, when we first started to hear about the data coming out of Wuhan and then Italy, we were already planning and preparing for that first surge. Equally, once we were in the surge, we were already planning and preparing for the recovery or for the sustainability of providing services during the outbreak period. And I think, as everyone's alluded to, that way of working has served us well so far. The use of data, the collaboration across the system, the emphasis on research and partnership with the university, as well as taking whole network to multi-professional approaches. And we will continue to embed those over this phase. I think the only thing I will say on top of that is, arguably, we're in a harder phase. As Charlotte has alluded to, people are tired, they're very committed, and they really desperately want to care for patients and meet the needs of their patients. But also, all of us are coming to terms with the fact that this is not going away, and this is now the reality of the way we work in health and care, the way we need to practice medicine, primary care, and community and social care. And that's quite a complex undertaking, and it means lots of people working differently for a long time. Now, the extent to which we can make that truly focused on optimizing clinical outcomes and making it truly patient focused is key. If we can embed the benefits that we've already started to see through the COVID period and embed those changes to the way of working and changes to the way that patients are interacting with services, then that's what we're all aiming for. I just don't want to underestimate the kind of the challenge for our staff and also for our patients and families as they start to internalize and work in this way for a much longer period of time. And I know that's affected lots of people in different ways, including the fact that you might not be able to visit your relatives and loved ones in hospital in the way that you could before, or your inability to receive a treatment or a diagnostic procedure in the way that you would before. And I think we're all just learning about what this really means. And I would also say bear with us, because we are really trying, and we're learning as we go. And the more feedback we get actually from our members, from you, as well as the more learning and sharing of good practice that we can get from hospitals and primary care colleagues across the network, the better, really. So thank you. That's our approach to this phase. And I hope I didn't make it sound too difficult.
Thanks, Nicola. I remember you and I going around some paediatric and other wards shortly, a couple of days after lockdown, and that was a time when we were a lot of patients were leaving the hospital in order to accommodate the possible number of beds we needed for the COVID surge. And I think we talked at that time, back in 3-4 months ago now, the worry we had about those patients who are not COVID patients and the impact this has on them. And I think that balance is probably the most challenging, kind of in a sense, professional, clinical and ethical challenge we've got as a hospital. And I'm acutely conscious that there are patients who are desperately worried about the delay in their treatment or their non-treatment or their non-diagnosis, and their families. So that balance is now a huge complexity, which you are picking up. Now, Nikki, I'm conscious of time. I don't know quite how this works, because the briefing is that we must finish this at 7:30. I think the only conclusion I can draw from that is we only put £5 in the Facebook meter. So we will But I think if I'm looking at Nikki right, if people have questions that we can't answer and the time still allotted to us, if they can still put those up as comments on the Facebook page, and we will come back to them hopefully that way if we think that's a big question that lots of people have and it's helpful for us to do. And Nikki's nodding to that. So I think we can, if we don't answer your questions now, we will try and answer them if you continue to put them on the page. So we've literally got 5 minutes. I think I'll focus those, if I can, on any questions we can deal with. And can I treat it now, just to say now, thank you to all our panel. You've been terrific and it's been really, really helpful. And we'll use the rest of the time now to deal with questions. So over to you, Nikki, to guide us through any questions we can now deal in the time.
Thank you, Mike. Okay, we have had a couple of questions come through. The first one is from Ali to say how many, and this is directed for James, how many Shield patients do you have and how are you advising them about their specific risks?
Okay, great question. Shielding has been a hot topic, and some of the surges in phone calls we've seen have related to various announcements about shielding. We have over 2,000 patients out of our 44,000 who are on the shielding list, which is higher than the national average. All of them will have had a letter initially advising them to shield, and that was suggesting 12 weeks to begin with. That was then extended to the end of June and has now been extended to the end of July. So we're providing support for them through our social navigator, our social prescriber. We're contacting all of those patients individually to see if there's anything we can do to help. And we're providing particular services, either home visits or into a cold site with maximal precautions for those who need healthcare. So it's been a big ask, but phenomenal response from our community and patients who are shielding about looking after themselves, protecting themselves, and indirectly protecting the broader community.
Lovely, thanks, James. And then I think a bit of a tricky question. This one is from Lorna. She says that she's referring to the fact that we have underutilized bed capacity at the hospital. And she wants to know, what are we doing to try and rebalance that? And was it local management or was it NHS England that dictated the over-allocation of resources to COVID-19?
Nicola, do you want to start with that?
Yeah, so I'll give you my take on how we scaled and prepared for COVID and what that meant for beds within the hospital. So I think we've all talked about how we needed to respond to this new infectious disease that we hadn't seen before, that was particularly virulent, and that we were just working out what that would mean, but we knew it would mean that a significant proportion of our patients would require critical care, and a significant proportion would be very sick indeed in hospital. And in order to do that, we had to plan, as Ben has said, for different scenarios. So what would it look like here, based on some sensible assumptions about what it had looked like elsewhere in other areas of the world, in China and in Europe, and then factoring in the data we were starting to see coming through in other areas of the UK. And that gave us a number of scenarios to plan for. We, of course, had to plan for what looked like a reasonable worst case scenario in terms of the numbers of patients that would need our care with COVID-19. And as Charlotte has said, that meant changing the use of whole wards. So a ward that had never been used as a critical care unit before now became an intensive care unit. Wards that had not been respiratory wards now became respiratory wards. And we had to make significant changes to the layout of the wards, as Ben has said, to enable people to put their PPE on and take it off again safely, to always minimise the number of outbreaks within the hospital, which we haven't seen really since the start of the pandemic. So we had to make really big changes, both to the physical layout of the hospital and also to the jobs that people are doing within the hospital. Some people were retrained, as Charlotte said, and were moved into critical care. Others were moved into respiratory wards who wouldn't normally work there. In order to take those people, those healthcare workers, from the jobs that they were doing at that point, and give them the right training and support that enabled them to feel confident and have the right skills to care for COVID patients, that meant of course, reducing the care we were providing in other areas in order to enable us to scale for our COVID response. So we were actually pretty lucky, I think, and our local population was lucky that we did not see the reasonable worst case scenario that we had planned for. But I stand by our decision to plan for that. And I think the clinicians you've heard from today would agree, but also it was their expertise, it was their analysis, it was their advice that was telling us that this is now how we needed to operationalise, and they were right. We've learned a lot about how we do it, how we could sustain that in a way that doesn't mean we need to turn other services off in the same way. And we've also learned a lot about, as Ben said, the impact of public health measures on community levels of COVID prevalence, particularly for our local area, but also the regional network that we support. So that's why at one point there were lots of beds that weren't occupied by people, and I've explained some of the reasons why. The other thing we've had to do during this phase is to essentially separate out areas within the hospital that are caring for patients who we know to have COVID-19, those who we think might do, and those who we are pretty sure don't. And it's really important that we have those red, amber and green areas within the hospital to keep those patients safe and also our staff. Some of them are coming in for procedures that would make them really quite vulnerable if they did then acquire COVID in hospital. So as you can imagine, if you're coming in for a surgical procedure, it's really important that we do everything that we can to protect those patients, a number of whom will also be immunocompromised and have other risk factors. So again, that's why we might at times have some beds that we aren't using fully on any given day, but that's because of the way we've needed to reorganise the hospital over this period.
Thanks, Nicola, and that's really helpful. And any of us who...
Charlotte was going. Charlotte,
I'm just conscious of whether the Facebook time clock of doom is
sorry.
going to come down on us. No, okay, Charlotte's then, and then yeah.
It was just to add to Nicola's point and give some idea about the scale of the response from the critical care that was needed. So pre-COVID, we normally have bed spaces for 32 patients to be on intensive care ventilators. At our peak, given that all of the other things that cause you to come to intensive care didn't go away, we had 40 people with COVID on mechanical ventilators, plus all the people that stepped down. So actually we had more people just from one single cause on ventilators at peak, with all the other stuff still happening for intensive care alongside, because actually elective surgery going away doesn't make a lot of difference to us because most of our patients aren't from that group. So we stole effectively nursing and other resource from all over the hospital to come and look after those patients because there was no other option. So whilst there may have been empty beds, part of that will have been a function of people like me needing their staff to come and look after them in other bits of the hospital.
Yeah, I think, thank you, Charlotte, thank you, Nicola. I think Lorna's question is absolutely a good one, because getting that balance right was a really important judgment. And it's really the pressing question now, as Nicola was saying earlier, as to how do we recalibrate back so that those patients who were not being treated can now be returned in some way to be treated. But remember, I don't know if anyone saw, but there was the programme on the BBC the other night from an A&E doctor and an intensivist in Cremona in North Italy, in Lombardy, right in the centre of this. And I know a village quite near Cremona. We used to work a long time ago, and I know the mortality rate there is horrendous. And they were just a few weeks before us, and they were overwhelmed. Their hospital and the Italian health service is a good health service. It's a well-developed health service. Hospital provision is good in Italy, but they were absolutely overwhelmed. And the reasonable worst case that Nicola talked about was actually if we were to have the same experience as Italy. And at that point, there was no reason to hope or believe that we wouldn't. So that was the nature of the judgment. But you're absolutely right, Lorna, that actually our ability to recalibrate back to those non-COVID patients, whilst, as Ben has said, it's still uncertain about coincidence or presence of COVID, that's the real challenge, and that continues to exercise, I think, all our minds and all our I was going to say all our waking hours, but our waking hours are extended because we're thinking about it. So it is there. So Vicky, what are we going to find? Have we still got questions, and what's, just advise me what's best?
I think let's wrap up for now. I think we've covered a large amount of information so far. So I think let's wrap this up. But any other questions that come through, we will answer them. And of course, this will be provided in a link on the website, as well as to the members themselves via email. So if you haven't given us your email address, please do so, and we can send you the link. But this was lovely. Thank you so much, everybody.
So thank you very much, Vicky. So I hope members have found this helpful. I hope it's been informative, and I think it'd be really, really helpful if you gave us a sense of whether this works for the conduct of continued communication, given the point that's been made tonight that we can foresee this being the way we have to conduct life for quite a while to come. So you'll find on, if you have any feedback, just please do send it back to us. You can email us at, this is all lowercase, foundation@addenbrooks.nhs.uk. I'll say that again, foundation@addenbrooks.nhs.uk. So please do give us any feedback. If you put questions up still on comments on the Facebook page, we will seek to address them. So thank you very much indeed for listening. Thank you very much for your continued support and challenge to us as a hospital, as members. We know how important we are to you and your families, and to the whole system of healthcare, primary care and acute, that James has contributed to in our discussion tonight. So thank you for that. And finally, just thank you to James, Charlotte, Ben and Nicola for what I found a very interesting conversation. And finally, if I may, I just want to say, hopefully on you as members' behalf, a profound thank you to all healthcare workers for what they have done, both in the hospital, and by healthcare workers, I include the porters and the cleaners and the caterers, because it's a team effort, as Charlotte said, and everybody who's helped us, but also primary care and those in care homes. I hope if one thing's come out of this is an increased value by all of us of the contribution that everybody makes to health and social care in Cambridge and beyond. So thank you to them. So without further ado, I think Vicky will now terminate us all on Facebook. So thank you.
I will do that. Thanks, everyone.
Okay.